Good evening to everyone. We have about 45 seconds before we officially start. So if you would go ahead and be placing your name and campus in the chat, ensure that your name is correct as it appears on the roster. All right. Good evening to everyone again. Ensure that you place your name and your campus in the roster. Ensure that your name on the screen is correct as it appears on the actual roster too. So you may need to make that name change if you're logging in on a device that has a different name than yours. So welcome to week 2. Hopefully everyone is doing well. Good to see everyone. So just a few housekeeping things. Just remember you can't be in a doctor's office, hospital room, or any of those restricted places during class. These sessions are recorded and they are viewed by the attendance administrators. There are times when we're doing the quiz where you can actually, if you finish before time, you log off, or either you can be off camera, but otherwise, and on break time, but otherwise remain on camera. In the event that you have to step away from the camera for any reason, take the time to find my name in the chat and send a message to me. The way that with the update, you have to click a few more buttons, it seems like, to find the person that you actually want to communicate with in the chat. So, but if you're having any issues, connectivity issues, or any other issue, please communicate that as well as to why you are not on camera. All right, so let's look and see where we're at. Let me pull up my screen here and where we're trying to go. So this is week 2. We do know that, okay, let me share here. Okay, so we're looking at communication and talking to those and being involved with the others that are on the team. Effective communication can mean the difference between that continuity of care or those breaks or either gaps or even care not even being rendered. So it's very important that we know who else is on that team and be able to communicate with them, even if we're asking questions for clarity. So communication is necessary. So as a reminder, remember you have for you all, for discussion question 1, the posts were great. You all made your initial post by that Wednesday. And remember, initial post are Wednesday, and then respond to at least 2 peers by that Sunday. So now we have another discussion question that's coming up. So we're looking out and inserting your answers for that. We will have a quiz. The first 2 quizzes, we'll take later in the class. And then here is our content for this week right here. So let's look back at one other thing here. I want to look at where the exam is. Let me see. I'm sure it's in week 4, but I just want to show it to you here. Just as a reminder, too, if you're taking more than one class, remember, most of exams, that first one is in week 4. So just be looking out for that so you can divide your time up, be scheduling one-on-one via email or Zoom or what have you. This is not just for this course, but our courses. We're here to provide that one-on-one if needed. So be thinking about what that's going to look like for you as we get closer to that first exam. And also, if you need that exam proctored on campus, make sure that you are communicating that in an email so that to include your campus dean, the course leader, which is Dr. Mary, myself, and Dean Brown in that email, so that a place and someone can be there to proctor that exam for you. Okay, so we're in week 2. Of course, we're discussing active listening. We will have our quiz. And then next week, which is week 3, you have NCLEX questions that are due. And then we will have another quiz. And then week 4 is that first unit exam. So that's where we're at. Any questions about those tests thus far? Are there any questions? We did place in the announcement. We went ahead and placed the exam review schedule. So I'm going to pull that up for you. And it is under exam review schedule for the term. So there are 3 of us. So the upcoming exam review, share my screen here. They are plotted. They are under exam review schedule. And so at a minimum, we would love for you to attend. We have them on different days and times. And Dr. Tenza actually does a Kahoot here. So, but come during the exam reviews with your questions or concerns, or even reach out before then so you can validate what you know. So this is exam 1. And know that if an exam review does take place, we do share those recordings. So be looking out for those as well. And just make sure that you're committing to at least reviewing your classroom recordings and those exam reviews. So just to let you know, I know exam 2 is not here just yet, but it's there already. So you can kind of be pre-planning. If there are any changes in the schedule, we'll let you know as soon as possible. But they start as soon as next Tuesday, Wednesday, Saturday, and then that Sunday. So various times. They're not mandatory. They are just strongly encouraged. Okay. So look there and see what you can add in your schedule. And I think that's it. And don't forget about the professional development paper that's actually due in week 6. I know some of you all are already working on that. Just go ahead, and it seems like week 6 is far off, but it does come up on you pretty quickly. We did put some resources in the announcement section regarding APA and even how to cite and reference YouTube video. We pretty much have all different types of APA examples in there. So make sure, because what's going to happen is you don't cite it properly, then your paper is going to pull it up as plagiarism. So make sure you take the time to look at those resources that are provided. All right, so let's go ahead and look into, let's validate where we're at. So let's share my screen here. Let's look at some information before let's just do. And you all can just unmute and just respond this time with this activity. No new information. We're just trying to recall and see what we know, what we remember, and those things that we still have questions about, which I'm sure we will answer as time goes along tonight. So we have effective forms of communication. Effective and ineffective. So as you're reading through scenarios, test questions, and as you're having your discussions, make sure that you are identifying what that concept is, because 2 letters change this whole word. IN changes this whole word. So effective communication allows the client to express their wishes, learn more information about them. It tells you or allows you to learn of what their preferences are. And then those things we want to take in consideration as we implement and decide on interventions. Then ineffective communication, it does the opposite. It blocks, it stops, it shuts down, it limits communication. All right, with that being said, remember we have to know the meaning of the concept, then we have to apply it. So here we go. Got an example. We got effective communication and we have ineffective. One allows and one stops or halter communication. So let's see which one is which. Here's some examples. So you tell me. So for the first one, in the chat, or either you can not, we're not going to use the chat for this one. Just come off mute and tell me, what do you think the first one is? The person says, the nurse says, you eat just enough to keep a butterfly and pigeons. You have to eat more.
Ineffective.
Okay, sounds like we all agree that it's ineffective. That block shuts down because that person may feel belittled. They may feel strange or feel like they've been disrespected. And so if there was an issue as to why they're not eating more than likely, if you're comparing them to a pigeon or a butterfly, they're going to shut down. Communication will be blocked. It will be halted. It will be stopped. Okay, so the nurse says, I noticed you did not eat much again today. Is there something else you would prefer for each meal?
Effective.
Anyone else?
Effective.
Effective.
All right, I agree. Effective. So we are stating, we're being assertive here. We're stating facts. We're being honest. This person did not eat much. And I think now in most facilities, if you don't eat at least 75%, it's considered not enough. A couple years ago, if you ate 50%, it was enough. But now, in a lot of facilities that we're going in, it is at least 75%. And if they don't meet that, we have to offer an alternate meal or some type of health supplement. So here it is. You are, again, this is also establishing that therapeutic relationship, which is what we want. You're showing interest. You're showing concern. I said, I noticed you didn't eat much again today. And then you're taking it a step further. Well, hey, is there something I can do? Is there a solution? How might we offer something? Is it not appealing? Do we need to offer different meals? Because a lot of facilities too, they always have that alternate meal. So, but they serve that main course. And here it is. This right here facilitates, it opens up communication. It allows that patient, we go back, preferences to be considered. It allows them to also, and we'll talk about autonomy here in a couple of weeks too. It allows for that autonomy to be entered into the patient's care and into the conversation. And we support them in their autonomy. Even after we say this right here and they still say, hey, I'm on a diet, I'm trying to cut back. At least we've opened up that communication and now we have a better understanding of why they're not eating, rather than comparing them to a pigeon or a butterfly and them shutting down and not telling us that. All right. Any questions about ineffective and effective communication? So I thought we were all clear on that. Active listening. The person that allows others to speak uninterrupted and responds appropriately to the discussion. Is that active listening? Do we agree or disagree?
Yes.
Okay. Yes, we're allowing the other person to speak. Even if we don't agree with what they're saying, we still allow them to respond and say what they need to say. And even if, like I said, they don't agree with what we're trying to get them to do, still that can enrich in that relationship, because the other person will be like, well, I didn't even agree with them and I don't want them to do that intervention, but they at least heard me out. So, I may need to have more conversation about whatever it is, because this opens up the avenues of strengthening that relationship. What about the nurse paraphrase what the patient stated? The nurse paraphrases what the patient stated. Is this active listening?
No. Yes.
We have a yes and a no. So
yes.
We have a yes and a no. Okay. So
yes.
What is paraphrasing?
Basically summarizing what the client is speaking. Like if you have like a doctor's appointment with the client, they're telling you issues and stuff going on, you just summarize it in shorter words or medical terminology.
Mm.
So you
Uh,
are, go ahead.
okay, no, I think it just like keep that same concept, but just saying in the different words, they're just trying to emphasize if it's that understandable from both sides.
Okay. And I'm pausing because I don't want to interrupt. I don't hear anyone else. So remember, so what is paraphrase here? So paraphrase is you're having that conversation, you're restating, you are summarizing what that patient has stated so that you can gain clarity and make sure that whatever was communicated to you, that you received it correctly. Because there are plenty of times when we're talking or having a discussion with someone what you said or either what they said was misinterpreted. So when we're paraphrasing it, it allows us to, put it into our own words, what we actually heard them say, what we thought we heard them say, just to ensure that what they said is really what we understood. Okay. The nurse asked the patient questions to be sure they have understood correctly. So here it
So
is.
that
Just
is active listening, correct?
yes, it is. It is.
Okay.
We didn't change what they were saying. Because remember, even when writing papers and we cite our references, we're not changing what those references are saying. We're just rewording that in our own words. And this is just a way to verify, summarize, clarify, I think is what one of you all said, what the patient actually said to us. So, and if think about it, if we don't do this, if we don't reword or we don't ask questions to be sure that we understood what the client said, we just go on, we just move forward, and we might be doing something that is not permitted or against their wishes. So we do want to ask questions. Active listening also involves a discussion, asking those questions and allowing that person to speak uninterrupted. So all these are active listening styles. It is just think about it. Is what's happening, the sender and the receiver, the discussion that they're having is information being sent and received and being interpreted and verified. And so if that's happening, then that's active listening. And there are times when a person can be hearing you, but not really listening to what you're saying. So if they're just hearing a voice and not really listening and interpreting what they're saying, then they won't be able to verify, what the client has actually said. They won't be able to summarize what the client said because they were just listening at the voice and not really understanding and taking in what the person has really said. Okay, so now we're moving on to assertive and non-assertive. Again, when you're reading test questions and scenarios, make sure that we are reading and gathering what the concepts are. Because here we have three letters that totally changes what the concept is or the understanding or the meaning of the word. So we have assertive and non-assertive. Okay, so someone tell me, share what is your understanding of assertive and non-assertive?
Is that being firm and then not as firm, or is that different?
Those are words that you can use. So being firm, but we're not being firm that we're being aggressive or that we're being assertive, but in firm that we are being honest, and we're offering those solutions. And then non-assertive is we're just, you know, okay, whatever you want to do, we're just kind of like passing the buck and not really finding solutions
So
that are
passive.
there. Yes, passive. That's the other word. Yes, it's passive. And so with that being said, so someone again, let me hear from you. Summarize what is assertive and non-assertive. We heard passive, passing the buck. For non-assertive, we said assertive was, not being aggressive, but being truthful, honest, and to the point. So someone else summarize those two for us before we look at this example.
I would say like assertive is being like confident, about like what you're saying. Um, something like that.
So you're being honest, and the information
Yeah.
that you're giving them is correct information.
Yeah.
So you're
It's
not
like
just
you advocating for somebody, like you passionate about what you're saying, like you speaking the truth. Like, I don't know.
okay. So you're calling, making that phone call to the doctor, and we'll talk about calling the doctor's healthcare providers here lately. And what we have observed is a patient has been administered pain medication. They have pain, their pain is real. We administer it, but that patient cannot function. Before administering the pain medication, this person can push the call light, they can press the button, they can get up and use the restroom. They are not incontinent. After we administer whatever that pain medication is, this person is hard to arouse. They can't feed themselves. They're incontinent. We make that phone call and we know, we let the healthcare provider know what our assessment findings are, what's happening. We administer this, we notice when we administer this medication, yes, this person doesn't appear to be in any pain, but this person has no control over their bowel or bladder, which is a new finding for this person. So you're being honest, but you're not being aggressive. And so non-assertive with that same situation is, well, the doctor ordered the medicine, the patient, at least they're not pushing the call light, or we'll just clean them up if they're incontinent. That's non-assertive. Okay. So, which of the following is this statement an example of assertive and non-assertive? So it says, it might be best for an increase in social interaction to occur. I think I read this word didn't make, the way I have it worded, you all didn't make any sense. So let me reword it here. It might be best for an increase in social interaction if the client's family and friends would visit more often. The client might have more social interaction if the close family and friends would visit more often. So you're in care plan, and they're talking about, because in care plan, of course, we are looking at everything from A to Z. We've done our head to toe assessment. We've gathered subjective, objective data. And an issue for this person is like social isolation. They're not interacting with others. And so the Nurse Lisa says, hey, it might be best if we encourage close family and friends. Of course, ask the patient and see if we can encourage close family and friends to visit more often so that that patient in room 201 would have an increase in social interaction. We can suggest that the patient in 201, if they want to participate in bingo, we haven't been playing bingo, but on their entrance survey, they put that they like to play bingo, darts, dominoes. If we include these things on the activity schedule and let this patient know, this might increase their social interaction. Are those examples of assertive or non-assertive?
Assertive.
Okay.
Assertive.
So we're being honest, we're offering solutions, and then we're including, again, that client's preferences, especially if we go back to that interest survey. But non-assertive, we see that this client is not interacting with anybody. They're not coming out to any of the activities. We notice that family members are not coming by. Months and months have went by, and this patient or client, they tend to not participate in anything, even the birthday celebration or any of the big holidays. And we just say, well, they just don't want to participate. It's okay. And it might be that they don't want to participate, but we at least need to offer some solutions and see if the behavior might change. But otherwise, if we just say, oh, it's okay, then that's non-assertive. We're not passionate. We're passing the buck, so to speak, is what you all said. Okay. So who does what? And the who is LPNs and RNs. So I'm gonna let you read the first two here. Then on your little paper, just jot down L or R, then we'll look at them on this next slide. Formulates nursing diagnosis. We have NANDA. That's what that list of nursing diagnoses.
The RN?
They're,
RN.
They're not medical diagnosis, but nursing diagnosis. Okay. A little opinion there. You got an R. Okay. I'm gonna write it down. Initiates health teachings.
RN.
Initiates.
RN.
Okay. So again, those one word, 3 letters can change a whole discussion. All right. And who reinforces health teaching?
LPN.
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 Completion of admission assessments.
RN.
RN.
Okay. Nursing supervisor for an acute care facility.
RN.
RN.
Okay. And nursing supervisor for a long-term care facility.
LPN.
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 All right, let's see how do we do. You told me RRL, RRL. Okay, I wrote down what you all said, and you're correct. All right, true or false? I'll let you read it, and you can tell me.
It's true.
True.
Okay, I'm just hearing
True.
true. True. Sexual harassment is the unwanted sexual references, either directed towards one from another or overheard in a workplace between others that makes one feel uncomfortable and interferes with the ability to work. Okay. And we agree. Right. All right. So the LPN is reinforcing follow-up care for a patient. So we just said that the RNs initiate, but the LPNs reinforce. So this is our scenario. We have a patient, they're being discharged from room 201, and that patient has been given a take-home folder that has discharge instructions in it. And this patient's being discharged from the urgent care, the hospital, the long-term care facility. But anyways, they're being discharged. They're going back home. And the discharge instructions, for example, could be about healthy food selections. They have hypertension. And so there are pictures and there's information about fresh fruits and vegetables. There might even be some vouchers in there where it's summertime where they can actually take those vouchers to the farmer's market and get some of those fresh fruits and vegetables. And or there might be information about ways to increase physical activity. For example, we can do sit-exercise. That's a big thing. A lot of our activities when we do the elderly population, we started off with we blow up balloons, and those balloons turns into an activity after we blow them up. The residents, they sit on each side of the table, and while music is playing, you're hitting the balloons, they're interacting, they're moving. So there are alternate ways of actually getting that physical exercise in without actually running and pounding the pavement. And so these discharge instructions, this take-home folder has all of this information in it. We've discussed it. We come back and discuss it with the patient. And as a result of it, we hope that they have understood and then that they make these healthy food selections and they increase their physical activity. So this interaction, we said all that to say this, what does this information address? The instructions,
Discharge.
discharge,
Teaching, education.
Yeah, education.
teaching or education. And then what's on the other side? Once we taught something, we hope the person has what?
Follow up.
They learn and they actually follow through with what we taught them. So all those were examples of teaching and learning. So again, we taught a concept, and our concept was healthy food selection. We showed them the information. We gave them vouchers. We even talked to them about the different food items, and they went and purchased the healthy foods. And then here, physical activity. We gave them examples of alternate things that they could do and still get that physical activity in. For example, sit-exercise. The little balloon activity, going up and down every aisle in the grocery store, even though you're not buying anything off those aisles, but getting those extra steps in. And so that person understood what we taught, and then that ensured that those actions say that learning took place. So teaching and learning. Got it. Okay, so let's look at this S bar. Think about the S bar. It's that structured way of communication. We have situation, background, assessment, and we have recommendation. So think back what each of those letters represent, and then tell me which part you are addressing when we talk about the admitting diagnosis. I'm going to jot them down here so we can refer back to them. Which part of the S bar? Admitting diagnosis.
It's B.
Okay. What are we saying? B. Okay, background. What about the date of admission?
Background.
Okay, I got that jotted down. Discussing the patient goals of care.
Would it be recommended?
Okay, I'm going to write that down. The reason for the call, the why. Why are we calling?
Situation.
Situation, right?
Okay. Orders that need to be addressed.
Would there be assessment?
Recommendations.
So we have assessment and recommendation. We'll look at it in just a few minutes. Procedures that must be done.
Recommendation.
Recommendation.
Okay. Lab or x-rays to be reported.
What's that? Report.
Recommendations.
Okay. What do you think is going on based on the data findings? An example is this problem life-threatening? What do you think is going on based on your data findings?
Assessment.
Okay, I heard assessment. Okay. All right. So that admitting diagnosis is that background. The date of admission is their background. So the recommendation is discussing that patient's goals of care, orders that need to be addressed. Those are things that really haven't happened yet, procedures that must be done. All those are recommendations. And the situation is a reason why we're calling. And then assessment is, what do we think based on the data, the assessment, the information that we've gathered. So which is this an example of? Nurse Lisa calls Dr. Bob because the patient was administered the incorrect medication. And Lisa discussed this with the pharmacist. Now she's calling the healthcare provider. What is that an example of? SBAR.
Would be situation.
Situation.
Yes, it's the reason, it's the why we are calling. Even though that situation involved that pharmacist, another person on the healthcare team, is still the reason why we're calling. That person was administered the wrong medication. All right, so what's the nursing shortage? Discuss concerns with the present nursing shortage. If there are not enough nurses, what is that comparing to the patient ratio? Is that an equal ratio, or is that ratio low for the nurse and high for the number of patients that nurse will have to take care of? What do you think?
Can you repeat that?
So there's a nursing shortage. Let's talk about the nurse-patient ratio. Do you think it's equal?
No.
Or as equal as could be? What do you think is that ratio a high patient ratio versus the nurse, like the one nurse and 5 patients, or is it one nurse and 2 patients? You say high, is that what you all say?
It'd be high. Yeah.
Okay. Well, what about the stress? You think it's high or low if there's a nursing shortage? You go to work that day and they're missing 2 nurses. What happens? High stress. What about the patient safety? Is it affected at all by staff not being there?
Yes.
Yes.
Okay. All right. So let's stop sharing. Any questions about any of those concepts? We reviewed information that we went over last week, and we're gonna move forward here. Any questions about that? Okay, and so hearing none, let's look at more on some of those concepts that we discussed. Let's look at communication a little bit further. Okay, so we kind of started talking about this, what is that communication? Is it one way or is it a two-way? There are sometimes that situations where there is a one way, that command is given. Can you think of an example where communication would be succinct, to the point, matter of fact? When do you think? What type of situation? Or is there a situation?
Delegation.
Delegation, is that one way or two ways? Because
It's two-way.
okay. So what type of situation would it be where it's one way, we're getting to the point, hey, this needs to be done, you do this and you do that. What type of situation is that? I'm trying not to give it away. Is see what else?
Is it an emergency?
Emergency, yes. So emergency, someone's coding. There's been a fire has been found in the building. Pull the fire alarm. Go ahead and get the remove the people from that area. Go out and meet the fire truck. Get the crash cart. So one-way commands is usually for emergency situations, and it is needed. They call it. Oh, that word just left my mind. Is different phases, but that's where you're giving those one-way commands, and you're not being disrespectful. It is urgent. We're needing someone to take control. And usually, if you're that charge nurse at that facility and the fire is discovered, there is a tornado in the area, you're giving those one-way commands. Everybody knows what to do. So you just need that person to step into action and provide those reminders, those specific things is what to do. And then we have that two-way. You all mentioned that when we're delegating, because remember, when we're delegating, we'll talk more about delegation here in the coming weeks, where that person, we make sure that they are credentialed and able to, be delegated to. A CNA to CNA or a UAP to UAP, unlicensed personnel cannot delegate to each other. And remember, we have to see first whether or not this patient is stable or unstable. If they're unstable, we're not delegating at all. But with this two-way, in delegation, we are communicating the correct information to the correct person. And also that information is verified from that person that we're delegating. So they may repeat or paraphrase what we asked them to do, whatever task we asked them to do. And then we have that feedback. And even though we delegated, it doesn't alleviate our duty of making sure that the care was provided appropriately. So that one way giving those commands is usually for emergency situations. And then usually in those plans, they have it in their policies and procedures. They identify who's going to be the person that's in charge. And even when you go on shift at night, there's a person that's in charge in the event that there are codes, that who's the code leader and things like that. And that person gives those one way commands. So there are some things that can affect communication. A lot of times, we are used to, as healthcare providers, we're doing our clinicals. We're used to all these sounds and scents and smells and seeing all this stuff. But just imagine a person that's not in nursing school, that's not a healthcare provider, coming into an environment and they're hearing all these bells and these whistles. And that stuff is distracting. Those things will influence that person's response to us as that nurse. They might not be as willing to allow you to proceed with their intervention because it's just too noisy. They might even respond inappropriately when you go in to ask a question during your head to toe assessment because they didn't understand what you said because it was so noisy they could not hear you clearly. They may be distracted. So, and that's called situational influences. And they're usually environmental and they do affect communication, usually negatively, meaning something is not going to take place. And so personal characteristics also affects communication, cultural characteristics, and then we want to put things into context and then look at what the background and the circumstances of the conversation is. Is this I was looking on the news earlier, they were interviewing a person that had just been involved in a fire. So, like, what's the context of that conversation? So that person may have been, their responses may have been while they were crying or tearing up, their responses might have not been complete because that situation was urgent. It was, life threatening. So therefore, had it not been for that, that person might would have had a long, drawn out conversation, completed sentence, correct sentence, may have had a subject and verb agreement. It would have been different based on the circumstances. So many times, for example, if you have a family member that has passed away, and we'll get into all of that, family members are not ready to make decisions right then. And if we try to push and move forward with them deciding things, then they will shut down. That will affect communication. So if this context or the circumstances require us to just remain silent and just be present and let them know we're there when they do decide, then that will promote effective communication. So always consider those circumstances. So we have verbal and nonverbal body language. So someone talk to us through the two. Verbal, we have about 15 minutes before we take our first break. So let's talk about verbal and nonverbal. Give me some examples or definition.
Nonverbal is like without speaking, body language, like somebody could be mad, so they fold in their arms or, stuff like that.
Mm-hmm. Keep going. Who else was it?
It was me, but I was saying the same thing. Nonverbal is like face grimaces. Like if the patient is in pain or something like that, they make their faces, they make noises. And then verbal, of course, is literally telling you, look, I'm in pain, my stomach hurts, something like that.
Okay. And so we do want to, when we're doing our head to toe assessment, we do want to, as we're asking our questions, we want to include what they're saying, what they're actually stating, but we also want to include those nonverbal cues as well. And then sometimes the verbal and the nonverbal, they bump heads. They don't agree. The person is saying that they're not in any pain, but we clearly see them doubling over, facial grimacing and things like that. And then that will allow us to ask more questions, reword, or maybe even ask one of our coworkers to come in and ask and see what can we get more out of the person. Because especially when that verbal and that nonverbal does not agree. It could be that they're not understanding what we have said. And so we want to make sure that we're speaking in what they call layman's terms. And so remember, for the most part, our patients won't be healthcare professionals. So we want to just make sure that we're just speaking in plain English or whatever that primary language is, but make whatever the words are that they're easy to understand. Nonverbal, facial grimacing, you all were exactly correct. Facial grimacing, moaning, folded arms, doubled over, looking away, crying, those types of things, moans. So even if our patients are nonverbal, there is still information that we can document. We can document when we're assessing pain, if that person cannot rate their pain on a scale of 0 to 10. If that person cannot state, no, I am not in pain, we can still write down and document those nonverbal cues. Either they have them or they don't. For example, this patient more than likely probably is in pain. So we could document facial grimacing, moaning noted. But if we're observing them and we're assessing them and we think that they're not in pain, but they're nonverbal, we can say no facial grimacing, no moaning noted. So either way, we still can document and address our pain assessment findings. Okay, and this is what we say: spoken word is powerful. Nonverbal communication is powerful and can both support or cancel the meaning of verbal communication. When they bump head, like the person says, "No, I'm not hurting," but then we look and see that they're crying, they're facial grimacing, and things like that. Okay. Nonverbal, I think we got all these: yawning, folded arms, not making eye contact, looking bored or distracted, facial expressions, volume and tone of voice. So our volume and our tone of voice can influence a person's response. Okay, so we have some active listening behaviors on the screen here. So take one and explain what it means, like restate it or paraphrase it. So we can, and anyone can just take any one of the terms and paraphrase it or restate it. Tell us how you understand it or what is your definition of it.
When I restate something, I just basically say the same thing over again just to make sure I heard it correctly.
Repeat, say the same thing. That's correct. And so you can, and so don't, it's like tomato. That's what we're doing. So we're saying restating could be saying the same thing or repeating what was said. All right, keep it going. Somebody else, select another term.
Clarifying is when you are asking the patient questions in reference to what they're here for or there for.
Okay.
Or
Keep
the
going.
situation. Yeah.
You said of the situation?
Yeah, or the situation at hand.
Okay. And remember, we're doing all this just to ensure that the things that we have received, the information that we receive is correct. Because we want to make, because sometimes what we hear is not what was actually said. Okay, go on, someone else. So reflecting allows us to look at the whole picture. Two, put into words the information you receive from the client. To me, I think of it as also incorporating that verbal and nonverbal information that we have received. And we, of course, we're repeating it. And then paraphrasing, we do this, we putting it in our own words, is how we would say it. But we're not changing the meaning of what they said, or we're not changing what they're saying. We're just saying it how we would say it. Okay. Minimum incursion is what I just did for you guys. So the next person. Next person. And usually, if we make those sounds or we use those words to say, okay, yes, go on, usually the person would. Thus, that's just minimum encouraging. We use phrases like, okay, yes, go on. Sometimes we even motion our head up and down because it conveys to that person. We hear them, we listen to them, but we want them to continue. And this right here, remain in silence. This is one I think, we as nurses, we have to get comfortable with, but it is therapeutic. Just being quiet. If the example that I just gave of the family members not ready to make a decision, our next steps is making that phone call so that the remains are taken care of, but they're not ready to select the places yet or just to talk about it. It is okay. Just let them know you're there and just remain silent. Summarize, stating the main data you have gathered. And then here you're picking out those keywords when you're summarizing, picking out those keywords. And then, of course, validating You're going to give those main facts and then of what you heard. And then the client comes and say, yes, that's what I meant. So we repeat what we thought, those main phrases or words. And then that patient comes back and say, yes. Or they may say, no, that's not what I meant. Or that's not what I said. Or that's not what I intended. Okay. Make sure that we know these. Let's see here. Open-ended and closed-ended. So our responses for closed-ended questions most likely will be what? What will our responses be? More than likely it is closed-ended.
I guess you would say non-assertive.
Like no, yes, yes or no.
Yes or no? What about open-ended?
It's like more information to the question that you ask.
Okay. So these are questions that we, the nurse Lisa, is asking the patient. Are you hurting? Is that open or closed?
Open.
It's open.
You said the question was what? I'm sorry.
Are you hurting?
It's closed.
Oh, that's
It's
close because
closed.
yes or no.
Okay. Can you tell me what you were doing when the pain started, and what do you
Open.
do to make the pain stop?
Okay.
Open.
Okay.
Open.
Because they're going to elaborate. Open, you get more things, more details. Okay. So that last question I asked, that opening question I asked the patient, the nurse asked the patient to tell them what they were doing when the pain started and what they did to help the pain. And they responded by saying, I ended up doing a hot bath. First of all, I was outside bending, picking up sticks. And then I took a hot bath and I put some of that ointment on. And then a focus question would be, we come in and we ask more questions. Well, how often does this back pain occur? How often do you have the upset stomach? Is it just when you notice when you eat your breakfast, or does it occur with every meal? And if it occurs with every meal, well, what do you have with every meal? What liquids do you have? Are you eating some of the same foods for each meal? Because then we're trying to see if there's a relation with a food item or one of the fluids. So those focus questions is what it is. It's kind of having the patient to tell you more about what's actually going on. Let's talk more about it. Give me more of a description. Okay. Okay, positive communication behaviors. I am encouraging positive communication. Being aware of our own body language. We go in, doing a dressing change. We already know that this dressing, this wound has an odor. You might want to do things prior to going in. So to assist with eliminating the odor or at least decreasing the odor, we want to make sure that we're not frowning and making gestures and things, and the person's not feeling well, they're embarrassed more than likely, because of the wound having the odor. That person is going to be even more embarrassed or feel worse if we go in and start making gestures and things and frowning, because of the wound odor. Okay. We do want to establish that eye contact, but we don't want to establish and sustain eye contact because that is frowned upon. That's considered negative. But we do want to establish that eye contact, look away and look back to them every once in a while. But here is not saying sustained eye contact. It's not leaning forward with those glaring eyes. That is negative. Okay, here's some negative communication. This one right here, I think, is what we tend to not think is negative. The patient says, hey, they love you. You've established that therapeutic relationship. They trust you because you've been assertive. You've given them honest communication. You have not been non-assertive and passed the buck. So they trust you. So why not ask the nurse, well, hey, what would you do? And so we're so quick to give a response, but actually giving advice is considered negative. But what we can do is give it back to them and say, hey, do you need more information? Is there something about this intervention that you don't understand that we need to rediscuss? And so you want to let them be able to make a decision. We don't ever want to give advice. And we don't want to do the false reassurances. Oh, everything is going to be okay. Based on what your healthcare provider has went over with you, those are the expectations. Outside of that, there's no other information that I have to offer because they may, we don't want to say, oh, everything is going to be okay. Every patient that's had this surgery, they've been fine. We don't want that because that one time something could happen. And we don't know that everything is going to be fine. That's why they come in and give that part of that consent. Consent is giving the good, the bad, and the ugly, the things that could happen, the statistics on the success rates and the negative parts of the surgeries and things that could go wrong. So we don't want to do false reassurances. And then usually the others you all we do okay with, but they're giving advice. We're just so quick for it because we have the solutions. And people look to us for everything. And you might have a huge knowledge base about whatever it is, but we don't want to give advice. Okay. When we go in, we want to introduce ourselves to our patient. We do want to talk in layman terms that they can understand. Remember, a lot of this stuff, patients are not familiar. Now, there are some that's going to, they've had the disease process a while. They learn how to manage it. They're not as fearful. But the unknown, usually we're fearful of the unknown. And then we talked about those environmental factors that we need to think about. Communicating with others, your instructors and staff and everyone on the healthcare team, we do want to remember, that we're committed, we're passionate. I think one of you all said about providing this care. So as a result of that, we want to be respectful. We want to be trustworthy. Tell the patient if you said you're going to come back, go back. If you can't, send someone else to say, to respond or to go back to that client's room. Be honest. You want to empathize. Be sensitive. It's so if you've made a mistake, then don't be so hard on yourself. Do move forward with doing the correct thing, but don't just beat yourself up about if you've made a mistake. Become more knowledgeable. We're life learners. We just learn something new every day. Different settings. We have different patients. Depends on what setting you go in. You're going to have different patients every day. Even in those long-term care facilities, people get discharged for whatever reason. You have admissions. Of course, we can't get away from that patience, having patience. And we're just committed or passionate. Okay. And we talked about SBAR here before: situation, background, and then the assessment, and then the recommendation. We'll stop right here and we'll pick back up. We'll see you in 5. Go to our first break. We'll take 5 minutes. All righty, let's reconvene and move forward here. So we're gonna finish this PowerPoint on out, and then we'll switch gears and do a Kahoot or two, so we can look at that same information in a different way. All right, let me find the PowerPoint. So we had started talking about SBAR. It's just a structured way to keep us so that we don't forget anything, that we communicate effectively. It's a great thing to help us to communicate whatever it is, depending on if we're handing off or if we're calling that healthcare provider. So that everything pretty much is thought about and not forgotten. So you all said this S was the situation. What is the reason? Why are we calling? What has happened? What has prompted this telephone call or this communication? And of course, we're including our name, the unit, the patient's name, and then their problem. So just remember too, when we're communicating, we really are the eyes and ears of that healthcare provider. Because if we're having to make a call, they're not there. The healthcare provider isn't there. So we're the eyes and ears. So we're going to give them enough information. You know, for the most part, they have a large clientele. So we want to make sure that we have given them enough information so that they can make an informed decision about what's the next steps for this patient. So that situation, what is the reason for the call? You know, we're including who we are, and then the unit, the client name, and the problem, the why. What is going on? Why are we calling? Background includes that admission date. You know, this patient's been here for 3 days. This patient's been here for a month. They're newly admitted yesterday. What was that admitting diagnosis? What's the current vital signs? What medications have we administered? Do they have any allergies? We don't want the healthcare provider to order something, a medication or a treatment or something that they're allergic to. So make sure we include that. We do go ahead and include the IV fluids that they're actively getting. You know, if they're HELP blocked, we say that. Okay, and their code status. Then for the assessment, what do you think is going on based on the data findings? For example, is this a life-threatening problem or not? And then those recommendations, those are those goals of care. What needs to be done, including a consult? Are there any medications or any lab orders, labs to be drawn, x-ray to be done? Does this patient need to be transferred to a different level of care, different facility, a different floor within that same facility? Okay. This is handoff. You know, you're getting ready to go home and next person's coming up. The information is similar, but we don't have to give much. Like we don't tell, you know, we don't have to say, you know, who we are and the patient's room number. Because for the most part, that's going to be on whatever, usually that's on a standard form anyway. So we're just giving the situation. We're handed out, we're getting ready to go home. And so we have patient in room 201. They came in last week. They came in for therapy. Have a diagnosis of right hip replacement. Give those background. Patient's been pain-free, required no PRN medications, had labs drawn this morning. Glucose was, you know, within normal limits. They ate for breakfast 75% and 120 of fluids. For lunch, they had, they didn't eat anything. They refused a meal. An alternate was offered, and a health supplement was offered. The patient still had 0% for lunch. They required 2 persons assistant with they did receive a bed bath with 2 persons assistance. Person required setup help. Vital signs, we usually give those the latest set. Right here, we give usually the latest. Now, there was a big change in their vital signs. We can give both. So we can establish that baseline so the next nurse can see what has been happening. Okay. And again, what's those goals of care? What needs to be done for that next shift? Are there any, because you're going home, remember these patients are receiving 24-hour care. So yes, there's some things that you're not going to get a chance to complete. That means you stay there hours and hours and hours and then work the second shift. That's why that next person is coming on, so that continuity of care so that care can continue. Okay, patient will need a UA in the morning. Patient receive their first dose of antibiotics. The next set is due, at 6 p.m. That care has to continue. So we do want to consider when we're communicating the lifespan of the person. So when we're communicating and what may be being communicated to us. So our patient is an infant, we're communicating to that family member or that responsible parent or guardian. And because our patient may be crying, they may be cooing, they're not actually communicating to us, or they could be, because they could be crying and that could be nonverbal. But there's someone responsible for them. That's what I'm trying to say here. Tantrums are usually under this lifespan, school age. Vocabulary starts to increase. They're learning new words. And even though at the adolescent age, vocabulary is very great, but then they tend to not be as verbal about things. So we establishing that therapeutic relationship is going to be important. So that if there's something wrong, they're not feeling good, there's a pain, that they will be open to tell us about what is going on. So email etiquette. We know about the using the inappropriate languages, using the all caps. We don't do that. We determine whether or not an email is the best way to send the message. So we're needing to communicate with a healthcare provider. Usually there's some that still have pagers, beepers as we call them. There's some that you can dial directly into their number. There's some that you call a number in what they call a waiting service. That's not what they call them, but someone answers the phone and that person communicates directly to them and asks them, and that person, the healthcare provider, calls back. So, what is the best way? They have different ways of being communicated. And usually they have an alternate method as well of being communicated, just in case you can't get them on that first way, then there's an alternate. Especially like one that I can think of where the facility was undergoing some type of phone system change. That phone system company was out working. I think maybe they were working on the lines or something. And so usually we would call in to the answering service. That's what I was trying to say. And the answering service would notify the healthcare provider and they would call you back. But that number that we normally use, we couldn't use. And had they not communicated to us not to use that number, that phone would ring and ring as though they were really there. And so determine what is the best way to send messages to that healthcare provider. Some use, we say email, but some of the facilities have their own type of mail. And so if that's the best way, it's just the best way. But determine that you want to keep our sentences and paragraphs short, be to the point, do not leave out any information. Be cautious with humor. The person sees only the written words. So make sure that when we're communicating specifically what we're trying to communicate. Use that S bar to guide you. And we talked about using the capitalizations. So when charting, be sure to take the time to chart. If they decide to call 1-800-DIAL-A-LAWYER, yes, they'll put you on the stand and they'll get your deposition, they'll get your verbal testimony, but they're going to go back to that, what you documented, because more than likely what they're asking you about is something that happened a long time ago. And so, some things you remember quite vividly, but they will rely on what you documented. So make sure that your documentation is accurate, is factual. Give as much detail as possible, but you want to be brief and to the point. You're not just using all these words and words and words, and you're not really talking about anything. But you do want to use enough descriptive words to lessen the chances of confusion. If there's a wound, we should have, what's the shape of it? Where is it at? Left, right? Or is there any drainage? What are the measurements? So be clear, concise, and to the point. Other types of communication: cell phones, text messages, social media. I'm not sure about social media is a type of communication, but I'm not sure about communicating any information about a patient. But that is just a form of communication. Okay, conflict resolution. You might be on that committee. Conflict is a part of life. You know, we want to sift through and get the facts. You want to gather as much information as we can so that we can identify what is the conflict. Because a lot of times what they're saying right then and there, more than likely, is really not what caused the conflict or what the conflict is really about. But as you gather more information, whether or not it's through written statements or individual interviews, then that helps you to come up with what is that conflict so that that conflict can be resolved. We do want to listen and learn and do not assume. And then we do want to be respectful of everyone's opinions, you know, and what they have to say. All right, so we're gonna stop sharing now. Let's go to a Kahoot. Let's do some active listening. Let's do who says what. Nursing process, who does what. Let's do that one. I think that one has a few slides. Let's see here. So, we don't want to cancel our meeting. Let's go to Kahoot. I'm gonna pull it up on the screen here. All righty, let's do this one. Host a live. We're gonna do host a live. And then the next couple, we'll just change up the learning. We'll do the flashcards and so forth. So that way we can look at the same information in different ways. All righty, let me share my screen and log in at least with your initials. You don't have to put your whole name, but at least with your initials and log in. Let's see, let me move this out of the way. That's my video off. I don't know what that thing doing. Okay, and the game pin is 19762. 19762. Log in, log in. All righty.
Wait, I
And
need to again.
okay. 19762. So don't answer trying to get all the points. I want you to read. Hopefully, I've worded them correctly because remember, these are just something I put together. But read, identify the concept, go back through your database, what you know. Does it match or does it not match? And make your selection. And here we go. Okay. The blood pressure medication was administered. Blood pressure is higher or lower or whatever that value was. Patient was administered pain medication. Patient continues to complain of pain, continues to rate the pain at a 5, left arm, so forth and so forth. Whatever those findings are. Yes, we want to report those. Implementation is carrying out orders. Does that match? Is that correct? Is that true or is that false? Okay. Implementation is carrying out those orders, is doing. It is, an example would be administering that injection, reinforcing the teaching on how to take self blood pressure measurements, inserting that Foley catheter. Implementation is doing, is carrying out those interventions, is performing those interventions. Just trying to think of different ways we could say that. RN and LPN both carry out orders independently. Carry out, implement, do orders, perform orders. Just trying to think of other words or ways that we can say this. Is this true or false? Is this correct or incorrect? Okay. And we do, because think about it. You know, we can reinforce teaching. We can administer medications. We just said carrying out orders was implementing. So yes, we can. Every time we administer medication, RN doesn't have to be there. When we insert that Foley catheter, and RN doesn't have to be there. The RN does the Foley catheter, the LPN doesn't have to be there. So we implement, carry out, perform orders independently. Just trying to think of different ways to say that without changing. During planning, the LPN collaborates with the RN. During planning, they talk, and then this other little thing over here, I don't think is anything. So during planning, is this true or false? Is this correct? If it's correct, it's true. If it's incorrect, that means it's false. Is this a correct statement or true statement? Okay. LPN uses NANDA to formulate diagnosis. What is NANDA? NANDA is those lists of nursing diagnoses. They're not medical diagnoses. Who comes up with or formulates the diagnosis for the patient? And remember, answer choice has to be all the way correct. While we do use NANDA, who formulates them? It's what would make this true? Somebody come off mute and tell.
The RN.
RN. So make sure that the entire answer choice is correct. If these 3 letters were 2 letters, RN, then this would be correct. We do use NANDA, but who formulates it is the RN. So make sure, test taking tip, make sure the entire answer choice is correct. Go back to what you know. If it doesn't match what you know, then it's not correct. Okay, the RN gathers information during the assessment. The LPN gathers this data dependently. What is dependent? What does that mean? Does that mean that the RN has to be there while the LPN gathers their information? So doing the head-to-toe assessment, the RN has to be there? No. So that's what I'm trying to just go through the thought process. So how you should be reading your answer choices and saying, this word says dependent. That means that the other person, this RN, must be there because the LPN cannot gather this information by themselves. So in fact, there are 2 phases where the LPN is more independent, meaning that the RN doesn't have to be there. And this is one of those phases, during that assessment phase. Because remember, we go in, we ask our questions. As the LPN, the RN does not have to be there. So that means we are independent during this time. Even though LPNs are not independent practitioners, during this part of the nursing process, we function more independently. Okay. All right. So let's stop on that one. We did pretty good on that one. Any questions about anything I've said, anything that you've seen? I'm trying to reword things because if you see it in a different way, it doesn't mean that it changes what is being said, unless it really did change. But if we're just saying tomato and the answer choice is saying tomato, they're still talking about the same thing. Now, if what you know and understand is an orange and the answer choice is an apple, then that's not the same thing. So you got to have that knowledge base. So when you are presented with, trying to find that Kahoot so I can turn it off. The information, you gauge it, you put it up, it's like, does this match or is this correct? Whichever words that you like. Okay, let's look at another one here. All right, let's look at this one. Let's see. Let's do maybe learn. I think we did learn. What was flashcards? Let's do learn. I think that's the one where you don't log in. Let's see. Okay. All right, let's share my screen here. All right. Role and responsibility of the LPN. You tell me what to select. You can just say red, blue, yellow, or green, or whatever I need to select. Of the LPN.
Green.
Green.
Okay. Let's go back. What would make this one correct?
Long term.
Okay. What would make this one correct?
Reinforce.
Okay. Got it. If it doesn't match what you know, it is incorrect. Okay. What part of the nursing process do this information belong? Discharge instructions from the emergency room.
Blue.
Blue.
Okay. So we have taught something. Remember the examples we gave: physical activity, selecting healthy food choices, doing finger sticks. And the list can go on and on. We are teaching, and hopefully they have learned and understood. That's what those discharge instructions are about. And it helps them to manage the disease process. Okay. Which part of the S bar? We know what the SBAR mean. Discuss patient goals. Which part?
Recommendation.
Okay. All right. Correct so far. Which part of the S bar? Change in mental status, decrease in urine output.
Assessment.
Assessment.
Situation.
That's why we call the reason for the call. So let me go back here. So we say that there's been a decrease in the urine output. And then part of the assessment, we can say, well, it was, it went from, at least however much an hour. Now it's down to this an hour. So that'll be part of the assessment. But we're going to call because they really have that decrease in the urine output, because that's a problem, because they should have more than that. And then the assessment part, we will get more details about it. Okay, and the same thing with the mental status change. We noticed the mental status change. Our assessment findings are initially they were oriented times 4. Now they're hard to arouse. They're mumbling. They're not responding verbally to any of the information that we're asking. Okay, each member has a part or a function that they fulfill on the healthcare team. The care is divided up. So this is talking about physical therapy, speech. Is the care divided up? What'd you say? I didn't hear you. What'd you all say?
Yes, it's true.
True.
All right. So that's another word that we can use. We can say yes, true, correct, false, no, incorrect. So whichever those terms you like to help recognize what the answer is. Okay. Patient-centered care is being disrespectful, this should have a C in it, respectful. The actions are dependent on what the individual needs. The actions are dependent on those that have the same diagnosis.
Blue.
Blue.
Yellow.
And yellow.
Okay.
Yeah, blue and yellow.
These three little letters. So make sure we're reading and making sure, because there's so many times like, oh, I thought that word said. Okay. Sexual harassment. Coworkers making sexual jokes, unwanted sexual references. A luncheon is planned for one person. A luncheon is planned for the department.
Red, blue.
Red, blue.
Blue and green.
Red, blue, and green. Okay, let's see.
Yeah, green.
Okay. All right. The LPN initiates teaching.
False.
False, no, or incorrect. Okay. The LPN and the RN formulate the nursing diagnosis.
False.
True.
I thought it was just the orange.
Okay,
Oh,
so
yeah.
what is it? What's your final answer? I select, it won't let me select but one, and then I have to go, which one am I selecting? True or false? What y'all think?
I'm saying false because I thought it was just the RN.
Yeah, it's
Yeah,
fine.
formulate. The word formulated makes the difference. Yeah, it's
So we're
false.
Yeah, we don't formulate diagnosis.
Okay. All right. Active listening is paraphrasing what they heard the patient say, the nurse asking questions to find out information for a family member, allowing others to speak uninterrupted, the nurse asking questions to ensure what they heard is correct.
Red,
Yellow, green.
orange, and green.
That's it. That's the final answer.
Yes.
Okay. Finding out information for a family member, that's violating HIPAA and everything. Communication involves nonverbal cues.
True.
True.
Facial grimacing, moaning. Okay. Communicating with others directly and honest manner without intentionally hurting anyone's feelings is being assertive. Is assertive.
True.
Speaking directly and honest.
True.
Okay. All right. Looks like we rocked on that one. All right, so let's go to our next little PowerPoint here. Are there any questions about any information that we went over so far? Let's see where we're at here. I think we move on to chapter 9. I think is what it is. Yes, chapter 9. Okay, so what are some things that nursing in the 21st century? What do you know about some things that changed as the 21st century came in about nursing? What did it do in reference to?
Technology.
Say that again, I'm sorry.
Technology.
Technology. What else?
The way they do things, as far as like detailing.
And so speak to me in reference to nursing programs and their salaries. What happened? What's different about it?
Oh, pay like far as payment, like how they
Mhm.
do it. Oh, so they get paid more.
Okay, so the salary gap has narrowed, meaning they get paid more. What about nursing programs? What happened in reference to nursing shortages in nursing programs? What happened to those nursing programs?
They made accelerated programs.
Yes, they have all different kinds: accelerated, hybrid, night, day, evening, part-time, full-time, online, a mix. So nursing shortages contributed to the change in nursing programs. So hence you see all the different types of programs. There's not just a one size fit all. It used to be you used to sit whatever days of the week in brick and mortar, and that was it. Now, because of the nursing shortages, nursing programs change. The way they look, they're different. So we have a salary gap, it narrowed, meaning that there was an increase in pay. Nursing programs, they change. They look different. There are many options. So what did the National League of Nursing do in reference to our role as an LPN? What did they say about our role? Our role was what? Just as important as the RN's role. So they recognized us. They said, hey, the LPN is a very important part, excuse me, of the healthcare team. All right. So tell me the parts of the nursing process. While we know that the LPN is not an independent practitioner, but which parts of the nursing process do the LPN function more independently?
Implementation,
Which is also what to the orders,
carrying out orders.
carrying out those orders, and what else? What's the other part that we are independent?
Assessment.
Assessment, which is what are we doing to that data? We're collecting it. Exactly. So don't get tripped up on those words. So collecting that data, that is that assessment. That's the head-to-toe assessment. That's getting that SNO, that subjective and objective data, and then that implementing. So what are those terms? And we talked about this last time, and we're going to talk about it again. I'm just doing like a little fact check. The United States Department of Vocational Education, they selected some words to describe our scope of practice as PNs. What are those terms that they said? Oh, we use these words because you all do a lot. And so these are the terms that we've come up with. This describes your scope of practice. What are they? Think about what we do from day to day, from moment to moment. Go in, we turn, we position,
We recognize.
Mm-hmm. Recognize.
Advocates.
Yeah, we're an advocate. We determine that something needs to be done. That's how we advocate. We appraise. We make those judgments whether or not, hey, we recognize that this is a change or this person is the same. This is their baseline. Or we recognize and understand that this medication has side effects. And this patient is exhibiting these side effects. Remember the example that I gave you? The person's in pain, but we give them medication before they're independent. This patient is knocking them out. They're incontinent. They can't even call for assistance or anything. So those terms are, again, we determine, we appraise, we recognize, and we judge. We make that judgment saying, hey, I don't think this patient should be zonked out like this when we know that this patient's baseline is they are continent. I think we need to call that doctor. Okay. So can we have these tasks delegated to us as an LPN to do a dressing change? Can that be delegated to us as an LPN to complete?
Yes.
Yes.
Okay. Can we remove or insert an indwelling catheter?
Yes.
Yes.
Can we administer medications?
Yes.
Yes.
Okay. All right. So now let me pull up our next little PowerPoint here. Get pushed through it. Let me just do another little fact check before we move on to it. I'm getting to it. Okay, so we have administered the medication. A person's on an antihypertensive. We check their blood pressure, we administer it, we wait at the time, the person's blood pressure is still elevated. And so, what do you think we need to do?
Do the nursing process over at least the.
If they have a medication on file for the blood pressure, you provide the medication after you already checked it, and then you document that the blood pressure was such and such.
We did
Before
that,
and after.
and we rechecked it. The blood pressure is still high.
If they have a blood pressure medication on file, at that time we're able to provide it.
We've already administered. We rechecked it.
Oh,
The blood pressure is still high.
You reach out to the charge nurse and let the charge nurse.
Got it. We collaborate with that registered nurse because more than likely, we need to adjust that care that's being provided. That patient may need more medication or different medication, but we want to collaborate with the RN so that that care plan can be adjusted. Because right now, that care plan is just saying administer the antihypertensive as directed. So we went in, we administered lisinopril, whatever it was, we gave it. We rechecked the vital signs of blood pressure. That's all the interventions say to do. But we noticed that this blood pressure is still elevated. We need to reach out to that charge nurse, that RN. All right, subjective, objective. So tell me, what is subjective information?
Whatever the patients say.
What is objective information?
What we find, what we gather.
Okay, so the patient rates their pain as a 5 on a scale of 0 to 10. What is that? Subjective or objective?
Subjective.
We're counting the respiratory rate. What is that number that we get? Subjective or objective?
Objective.
Okay. When we get that abnormal blood pressure measurement, we count those respirations and they're abnormal. We listen to that the chest sounds, the heart sounds, and we're like, wait a minute, am I hearing that? Those sounds like this person has crackles or rails or bronchi or a murmur. Before we move forward and report those, what do we need to do? Before we report the elevated blood pressure, before we report that finding, what do we need to do? We want to do what? We want to repeat and make sure that what we got was what we got. Sometimes there's malfunction in equipment, especially if we get a significantly high number and that patient hasn't been, running that way. And it could be, but we want to verify that blood pressure measurement, that glucose that we got, that those findings. You listen to the chest. Wait a minute. Let me listen again. Is that what I really heard? We want to repeat just to verify that that is correct. All right, so let me pull up so we're still saying the same information. I'm just repeating it in a different way and asking it differently, but it's still the same. So remember, you go back to what you know. If it matches what you know, then it's valid. If it doesn't, then that means it's not valid. It means you don't want to pick that as an answer choice unless they're asking you which one is incorrect. Okay, I just downloaded chapter 9. Let me do it again. We go. Okay, so chapter 9 talks about communication. Got 3 styles. I will share my screen. We got assertive, of course, we got non-assertive, and then we have aggressive, which we kind of talked about earlier. Okay, so what did we say non-assertive was? We said passive. We also said some other terms to help us remember that.
Not aggressive.
Not aggressive, passing the buck, passing it on. Okay, got it. Is aggressive, is that therapeutic? Is
It's
that
negative.
positive? It's negative. Got it. Okay, non-assertive. Usually, I guess the person is, fearful of how the patient may react. And so they just kind of pass the buck, and it's really a form of being dishonest if we're not going to be assertive and tell the truth about it. We said aggressive is negative, and some examples of it is when I said leaning forward with those glaring eyes, we're making statements with our gestures, and they're not nice and neat. They're offensive. They're aggressive. Aggressive violates the rights of others. There's an attack on that person rather than the behavior. And then the body language, that the example that's given is that person leaning forward with glaring eyes. So assertive is being honest, taking a positive stand and being confident in that statement, speaking openly, but we're not violating anybody's rights. We're not demeaning. We are, we establish that eye contact. We maintain that eye contact. Maintain is looking. You may look away, but you look back, but it's not that sustained and glaring. So, which is different. Negative interactions, denial. The nurse can use this as an excuse for, their personal responsibility. Rationalization, logical but untrue reason is offered as an excuse for the behavior. Instead of just owning up and just saying, whatever happened, this should have been done and this is what happened, and just being honest about it. Okay. In projection, individuals attribute their own weaknesses to others. Well, it was, Bobby's fault. It was Lisa's fault. It's why I didn't do what I was supposed to do. So this problem solving steps is almost like AdPi. We are going in doing our head-to-toe assessment. We're trying to see what the problem is of the patient, and we establish its goals. We gather this data. In this form, as we gather the data, we define what the problem is. That's how we lead to the RN leads to formulating that diagnosis. But problem steps, we have to gather information in order to be able to solve it. We can't solve something and we don't know what the problem is. So gather this information may come from statements. It may be interviews. It may be written statements, but we're gathering more information. A lot of times we have to look back 3 previous shifts to get that information, to get an accurate view of what actually might have happened. And then we decide on the goal. Are there any alternatives? How many solutions are there? And then we can try them out and then see if they actually work. And then the last step, which is not part of the nursing process, but we repeat the process if the solution is not effective, just to see if what we did, were those steps actually valid. So be careful with manipulation. Yes, we are on the healthcare team and we do encourage you to be a team player, but that does not mean violate policies and procedures and rules. One that comes to mind is we're given a break time, or a certain amount of break time, a certain amount of breaks that have so much time in it. And then you may have a coworker that, I don't know, they, for some reason, they need an extra break or extra 2 or 3 breaks. And they talk you into covering their patients. And so remember, while we encourage you to be a team player, we do not encourage you to assume duty. So the policy says take 2 breaks, 15 minutes apart. 15 minutes each break. The team worker, your coworker, they actually have taken 2 breaks already. They want a 3rd one. And so, hey, can you cover my patients? Well, the policy says we take 2 breaks, having you taken your 2 breaks already. So I'm sorry, not sorry, but no, I cannot cover your, cover. So you may want to rethink how, you can do those breaks differently on your next shift. Because if something happens while that person is breaking policy and procedure, you have assumed duty. If breach of duty, if there's an injury and approximate cause, and all that can be related back to that duty you assume while you agreed to, then the $1-800 lawyer is for you as that nurse. It's not for that person that's on break, because remember, you assume that duty. So when we tell you to be a team player, we're talking about assisting with things like changing their trash out, helping them restock their medication cart. Not anything that's going to cause you to assume duty for more than what's the patients that's needed. Work-related issues, evil does exist. So be careful, and we'll talk about it in a couple of more weeks about looking at workplaces and then identifying some issues or some instances where it might not be so safe. Something that comes to mind right off is a lot of times facilities will have their employees to park in different places than their customers. And usually those places are farther away. And if that's a facility that, that is in function day hours and night hours, what is that walk like? If you're having a park at that parking lot that's at the end, what's that distance? Is it well lit? Is a shuttle service needed? Do the employees that work the night shift, do they need a different parking assignment? Do they need to be able to park up closer than those in the daytime? Those are things that you can look at because evil is lurking and things do happen. Workplace injuries, ensure that if equipment is not functioning as it should, that we report those things. We don't continue to use that equipment. Yes, something could happen to that equipment, and as a result of it, we could be injured ourselves, and that you can have a life altering injury. So we want to report that. Okay. Factors leading to workplace violence. Environmental factors, workplace practices. We talked about that. Just identifying whatever setting that you decide to work in. You want to look at everything from A to Z. Where do I park? Where can I take my breaks at? Some facilities have designated areas where staff can take their breaks at. It's usually, a safe place. And if they don't have one, maybe you can help them realize that one needs, there should be a safe place, especially if the hours are 24/7 that business is operating. Some early signs of workplace behavior: look for unusual behaviors, lack of cooperation, hostile communication, spreading gossip and rumors, and uninvited sexual remarks, things like that. Don't put those things off or think that those things is nothing. Get it documented, address those things early on because evil is real. The next stages of violence, conversations focused on poor me. That person's is being the victim. If someone's saying things that are not appropriate, it's not a threat. Is not funny. Don't take those things as humor. So it is what it is. And so go ahead and approach those things directly. Stealing workplace property. Those things don't belong to us. Leave them there. Increase arguments. People are just being argumentative about whatever. Don't go ahead and seek in there be a conference or something. Address those things early on. So how can we prevent workplace violence? Makes a personal commitment to follow prevention guidelines. There's training, there's refresher courses, programs are being offered, and then make sure that we're reporting those things if something's happening. Take all threats seriously. Report them, document them, make sure that, family members know that, there's been a threat. So in the event that you're supposed to do your check-ins, no one wants to have to know where you're at all the time. But if you are, if you've been getting threats, you're deciding to go to the grocery store or take a drive or go out of town, just do a check-in with somebody. Well, hey, I'll call you when I get there. This ride is 3 hours. I should be there by noon. If anything changes, I'll call you. So in the event that you don't check in, they know which direction you were headed and to send for help. Evil is real. Sexual harassment, we talked about this, is unwanted. It's an abuse of power. The supervisor wants to just meet with that one person for dinner, to have an office party, but then only one person is invited. Most incidents are not reported. If you're the target, the issue, we want to confront that person, let them know straight up, unafraid, this is not wanted. What you're doing is offensive. Get it documented. Lateral violence occurs between nursing colleagues. We have 5 minutes before we take our next break. Sabotage, withholding information, backstabbing, nonverbal innuendos. So just make sure that you're keeping your logs, that you're reporting information, and getting things documented. I can't say it enough. Evil is real. People come up with some stuff, things that you can't even think of. They'll sabotage, set things up. So, but go back to whatever that policy and procedure is. If you're following that policy and procedure, and anything is off base, off, doesn't seem right, does not align, get it addressed. Vertical violence occurs between persons of unequal power. The behavior humiliates and undermines confidence. The person is bullied, ends up feeling fearful and unsafe. You know, this stuff is real. This stuff is real. So make sure that you're reporting it. Okay. A lack of action on the part of the nurse gives approval and permission for the perpetrator to continue the behavior. That's what they say. Well, the nurse didn't say, they didn't say anything about it. They know what they were doing were incorrect. Make sure you report it. Make sure you report it, and so that it is addressed. Okay, so we can go in and do our next break. So, and when we come back, we're going to go ahead and take our quiz and then finish up the rest of our content for this week. So we will see you in 5. All right, come on back. Do not click on the quiz because it has not been published yet. So don't click on it because if you already clicked on it, go ahead and click out because what's going to happen is it's not going to show up once I give you the code. So just some quick reminders here. Remember, your exam starts in week 4. Go ahead and get that dry erase board. If you don't want to purchase one, find one of those clear protectors, sheet protectors. You can write on those with one of those dry erase markers. You cannot use paper. Remember, if you're using it at the end, you have to show that board or that sheet protector erased. Make sure you have your IDs, get your 2 devices, and we'll publish that practice exam here probably by the end of the week. And make sure for all of your classes, you go in and do that practice exam. And that ensures that your computers are ready, that the specifications are correct to take that exam. All right, so let me put the times in here. I have to adjust them for our times because our course is on, I think, Mountain Time, I believe. So let me adjust the times. You will need a code. I will put it in the chat. And if you have questions after the quiz starts, communicate via chat. Do not come off of mute. Let's see here. Let me make sure I got my times right. So it's available ahead of time. I always put it an hour ahead. So, because sometimes it gets, let me just move it up 1 more hour. So it should be open here. Let's move it up. Okay. And grab this code. And it is case sensitive. So make sure the capital letter is capital. The lowercase letters are lowercase. And that you type the number, everything in as it is. Okay, I think I do have the times correct. So you should be able to see quiz 1. You are given, you don't have the code just yet. Gotta give you code. You are given the required time to take the quiz because we pushed our other break back toward the end. Once you finish with the quiz, you log off. But make sure that you commit to going back and looking at week 1 recording and week 2 recording, because next week we have to finish up everything and then we got that exam 1. So go ahead and be identified if there are any questions or concerns about anything. Can you see the quiz? I know I haven't given you the code yet.
I can't see the quiz.
I don't see it.
So come log out and log back in. Or hit your refresh. Yes. So don't, usually that's what I was saying. Don't click on it before I say click, because otherwise you can't see it. Do we all see it? Okay. All right. Remember, no resources can be used. Once you finish with the quiz, you can log off because the next thing is your break. But don't forget, if you have questions during the quiz or connectivity issues, send a message in the chat. Don't communicate by coming off mute. All right, I'm going to place the code and I'm going to go on mute here, pushing it out to everyone. And here we go.
Hi.
If we have clients that are being constantly readmitted or we're thinking they're non-compliant, we want to see what that client knows about their condition. We want to assess, we want to determine that client's knowledge about the disease process that they have going on. What do they know about that congestive heart failure? What do they know about that left hip repair? What do that client know? What is their knowledge base about the disease process that they have? Know that for standardized care plans, not every option may apply to your patient. So you have to go in because we make individualized care plans. We make them specific for that person. So what standardized care plans, what they do is everything in that product, if you click on diabetes, everything about diabetes pops up, but it may not apply to your patient. Remember, we make them individualized. So standardized care plans, you need to know, they're just based on all the research that's out there. So every option is listed, but not every option may apply for your client. So you have to go in and take out those things that does not apply. So for our patients that are transitioning from long-term care facility back to home, from acute care facility to the long-term care facility, even if they have a disease process, no matter what, we want to think all things safety. We want to implement those fall precautions because patients are in unfamiliar environments. Think about it. If they're dehydrated, if they have something going on with their diabetes, that level of consciousness might be altered, and that person's at risk for falling. We do know that the complications of falling can lead to death. So we want to put in those fall precautions. We don't want people to fall. We don't want them to injure themselves. We do not want that. Culture is a behavior that is learned by the members of the group, being passed down from one generation to another. It acknowledges the view of the world and others from a similar standpoint. Providing culturally competent care will include various rituals that patients may want to be part of their care. For example, we can allow that person of faith to come in and perform a ritual as long as what they're doing is not harming us or them or the patient, then those things are allowed. That is part of providing that culturally competent care by including the client preferences, which might include rituals, into that care. We can develop cultural competence by learning to be flexible when values differ from our clients' values. We want to recognize our own thinking and how culture affects our thinking. And we do want to discover our clients' unique. They are unique despite their cultural group. Just because they belong to a certain cultural group, that person still is unique within that cultural group. Each client is unique and has value regardless of the differences that may be observed or perceived, or that they have. Patients also have the right to live according to their personal beliefs, as long as they don't interfere with the rights of others. This is the philosophy of individual worth. A person may be deemed spiritual if that person has deep beliefs and values, and that they believe that guides their life, that there is some connection to a higher power. That is also called being spiritual. Concepts of spirituality and religion. There are many religious faiths practiced with the majority of them being Christian faith. Each faith has its own premise, and each member has an individual belief system. Now, ethnocentrism is the opposite. It is thinking that their way, or their way of beliefs, or the way that they do things is the only way. So that person might say something like, my culture's way of doing this, treating an illness, or responding this way is the only way. That's ethnocentrism. Critical thinking is outcome-based. We are trying to ensure that the clients are able to manage, that they come back to the optimal level of health. So critical thinking is outcome-based. We want those positive outcomes. Stereotyping occurs when someone attributes certain beliefs and behaviors about a group to an individual without giving adequate attention to individual differences. Okay, that is stereotyping. We just lumping everybody together. Lumping everything together. That's that stereotyping. So while we're being culturally competent, we want to think about if that client, if some of their practices are harmful, we want them to change those harmful practices or repattern them. But we do want to preserve the practices that are helpful. If they're helpful, we want to preserve them. But if they're harmful, we want to repattern those. And we want to discover the health beliefs of a client. You know, what does this client believe? And we want, that helps us to gain understanding of their actions and their acceptance of the interventions that we are trying to implement.